Okay, let's dive into something that I know is a big part of your world, headaches.
Yeah, they are a common presentation in ophthalmic practice in general.
Right, and I know that the pasted text excerpts that we have,
Mm.
they really highlight how crucial it is for neuro-ophthalmologists especially to be on top of these headache disorders.
Yeah, for sure. And that's kind of our mission today.
Yeah.
We're going to go into these excerpts and we want to try to extract like the key information about headache classification, diagnosis, and management. Really make it super clear for you guys, who are busy clinicians. So we're going to create this really kind of practical framework for you to use when thinking about headaches.
Absolutely.
The first thing we got to do is get the urgent stuff out of the way.
Right.
So what are the red flags in the excerpts that we should be thinking about that need immediate investigation?
Yeah, that's a really good point. I mean, right away, the source material jumps to new, severe, unexpected headache.
Right.
Any kind of papilledema.
Which is obviously a sign of raised intracranial pressure.
Right.
So you're thinking about doing some imaging or further investigation, any new neurological deficit. And particularly in an older patient, you got to think about giant cell arteritis. So those are your kind of non-negotiables that need to trigger an urgent workup.
Absolutely. Okay, so let's build our framework here. So the source material talks about the International Headache Society classification criteria, or the ICHD-3. This is like our map, right?
Yeah, it's our kind of our cornerstone. It gives us the structure for classifying primary headaches. And luckily, the excerpts actually kind of conveniently give us the main categories. Migraine without aura, migraine with aura, tension-type headache, cluster headache, and then medication overuse headache.
Got it. Okay, well, let's start with migraine. I mean,
Yeah.
it's so common, and the source material really highlights that it's these recurrent headaches, and they can really vary, Like the intensity, the duration, and the frequency could all be totally different.
Yeah, and it's much more common in women as well.
Yes.
So 18% of women versus 6% of men. So that's a big difference.
Yeah, big time.
Some of the common features they talk about, often it's a unilateral location, nausea and vomiting, can also get associated neurological and mood disturbances. But remember, not every attack is going to have every single one of these features.
Right, and I think that's where it can be a little bit tricky, right? Especially when it comes to neuro-ophthalmology, because the source material talks about how you can actually get a migrainous aura, but without headache.
Yeah.
So a patient might come in with just a visual symptom, but no headache.
Yeah, exactly.
And there's often a family history of migraine as well.
Yeah.
So what do you think about that?
I mean, it's really common that people come in complaining of visual disturbances and actually might not even connect it to a headache disorder, so you might have to kind of tease that out a little bit.
So true. Okay, so the source material kind of jumps into migraine and starts with migraine without aura, which is sometimes called common migraine, and this one seems like a bit of a tricky one.
It can be a little tricky. The text describes it as a headache with autonomic nervous system involvement. So you get pallor, you get nausea, but you don't get the typical kind of focal neurological signs or the ophthalmic signs that you see in classical migraine. So it often gets missed, actually. The premonitory features can also be quite subtle.
Subtle? How so?
Well, things like mood changes, difficulty concentrating, things that might not make you jump up and down and shout migraine straight away.
I see.
The headache itself, the text describes it as a unilateral, pounding, throbbing headache. Can start anywhere, it can spread, and might involve half the head or the whole head. And it also mentions retroorbital pain, which is really important for you guys to bear in mind, because patients might think that they've got an eye problem or a sinus problem, when actually they've got retroorbital pain from migraine.
Absolutely. So they end up in your clinic.
Exactly.
Yeah, totally.
So those are the kind of key things to be bearing in mind. These attacks can last anything from 4 hours to 3 days. Patients typically have photophobia, phonophobia, want to be in a quiet, dark room.
So as a neuro-ophthalmologist, what are those really key things, like the bullet points from the source material, that would make you go, I think this is migraine without aura?
So what you're looking for is recurrent headache. So at least 5 attacks that fit the pattern. And that pattern is the headache lasts between 4 and 72 hours. It has at least 2 of the following characteristics: unilateral location, pulsating quality, moderate to severe pain intensity, or made worse by routine physical activity. And then during the headache, you get at least 1 of nausea and or vomiting, or photophobia and phonophobia. So that's kind of your classic presentation.
Perfect. Okay, so let's move on to migraine with aura. I mean, that seems a little bit more straightforward, maybe.
It can be a bit more clear-cut. The source material really emphasizes the binocular visual aura that you get that affects the central visual field on one side.
Hmm.
Typically, it lasts for 5 to 30 minutes, and it often starts with a negative scotoma, which people might not even realize they have.
Yeah.
It's just a blind spot, essentially.
Yeah.
And then you get these positive phenomena.
Yeah, like those scintillating scotomas.
Exactly.
That shimmering, those zigzag lines.
Fortification spectra.
Yeah.
Heat haze. Less commonly, you might get things like tunnel vision, and they typically progress across the visual field. They progress quite slowly, and you should get complete recovery within 30 minutes.
Now, are there any other aura symptoms aside from visual?
So the visual ones are the most common ones.
Sure.
But less commonly, you can get a unilateral altered sensation, so pins and needles. You can get weakness, or you can get speech disturbance, so problems finding the words.
Got it. And then the headache that follows the aura. What does the source material say about that?
Yeah, so typically it follows the visual aura. It's often hemicranial, and often it's on the opposite side to the hemianopia, that you might get. It comes with nausea and photophobia.
Mm.
But the severity can vary, even in the same patient.
Right. Okay.
And it's important to bear in mind that other pathology can rarely mimic classical migraine. So you've always got to be thinking about that.
So what are those key things for diagnosis of migraine with aura then?
So what you're looking for is at least 3 of the following occurring on at least 2 occasions. So 1 or more fully reversible aura symptoms indicating focal, cerebral, cortical, and or brainstem dysfunction. So that's your visual symptoms.
Okay.
Sensory, speech and language, motor weakness, brainstem signs. Those are kind of the key features. And then temporally, at least 1 aura symptom develops gradually over at least 5 minutes, or 2 or more symptoms occur in succession. And at least 1 aura symptom is unilateral. And no single aura symptom lasts longer than 60 minutes. And then the headache follows the aura within 60 minutes. But it can start before or during the aura.
Yeah. And then they're really, really clear in the source material about making sure that you rule out any other disorders.
Absolutely. Migraine's a diagnosis of exclusion, really.
Right.
And they mention, rare possibilities like a permanent migrainous visual field defect, or an oral feature. And they also mention occipital epilepsy, which is very rare. But that's where people see colored circles during an attack.
Got it. Okay, so now we've kind of gone over the sort of classic types of migraine. The source material also talks about some other kinds of migraine. So let's just run through those.
Yeah.
First up, chronic migraine.
Okay, so chronic migraine is defined as a headache on 15 or more days each month for more than 3 months. And that's in someone with a history of migraine. And the text actually says that a significant proportion of patients with episodic migraine can transition to chronic migraine, but also that many of them can revert back to an episodic pattern if you treat them properly. So that's encouraging.
Yeah, it is good to know.
You've got to rule out medication overuse in these cases, because that can be a major driver.
Got it. What about retinal migraine?
Okay, so retinal migraine is a visual disturbance that affects only one eye. Now, it's a bit of a controversial entity. Some people think that actually a lot of cases are just recurrent ocular vasospasm.
Oh, yeah.
Rather than true migraine. It tends to affect young women, and patients might sometimes misinterpret binocular hemifield symptoms as monocular, which I'm sure you've come across.
Right.
The text says that investigations should be considered for retinal embolization, peripheral vasospasm, and that's because you can get permanent monocular visual loss with recurrent episodes, and that's likely due to vasospastic infarction.
Oh.
So that's not something to be ignored.
No.
And management involves avoiding any precipitants and potentially prophylactic treatment if it's frequent or severe.
Okay, so let's talk about ophthalmoplegic migraine.
Okay, so this is a rare one. It typically starts before the age of 10, and it's recurrent headache followed by a transient cranial nerve palsy. And often it affects the third nerve, so, you're going to get contosis, diplopia, the pupil might be involved. The thinking is that it's probably mostly due to demyelination these days.
Got it. And then there's familial hemiplegic migraine and basilar migraine.
So familial hemiplegic migraine is where you get hemiplegia as part of the aura. And importantly, there might be failure of complete recovery of the focal neurological features.
Okay.
There's usually a strong family history, and basilar migraine tends to occur in young females. And it's where you get your typical migrainous aura, but you also get features of vertebrobasilar arterial insufficiency.
Oh, okay. So like vertigo and things.
Yeah. So vertigo, diplopia, ataxia, altered level of consciousness. So those are the key things to be thinking about.
Got it. Okay, well, let's jump into migraine treatment. Um, the source material kind of breaks it down into general measures, acute treatment, and then prophylactic treatment. So let's start with general measures.
Okay, so the general measures that the text really emphasizes are lifestyle modifications. So this is all about trying to eliminate any potential migraine triggers.
Like what?
So common triggers that they mention: caffeine or caffeine withdrawal, alcohol, certain foods like aged cheeses, processed meats, hormonal fluctuations, so things like oral contraceptives, stress, sleep deprivation or oversleeping, long intervals without food. And it really emphasizes maintaining good hydration.
Right, so just good general health advice, really.
Yeah, exactly.
Okay, so what about acute treatment of an attack?
Okay, so acute treatment, the text mentions simple analgesics and antiemetics. So metoclopramide can be helpful if nausea is a prominent symptom. And then you've got your migraine-specific medications that we usually reserve for moderate to severe or refractory cases. So triptans like sumatriptan and ergotamine derivatives. And, occasionally you might need to go to intravenous agents in a hospital setting if it's really severe.
Okay, and then prophylactic treatment.
So prophylactic treatment, we start to think about if people are having frequent migraines, or if they're significantly disabled by their migraines. So the text suggests considering prophylaxis if patients have at least 6 headache days a month, or at least 3 headache days with significant impairment.
Okay, and then what about the prophylaxis itself? Does the source material have anything to say about that?
Yeah, there's some really key points about prophylaxis. So the first thing is that most of these preventative medications need to be taken for at least 8 weeks before you can really judge whether they're working or not. So it's important to explain that to patients. They need to give it a good go. And then if there are side effects or if it's not working after 8 weeks, then stop it and think about something else.
Okay.
Other reasons that they give for poor response are if the dose is too low.
Yeah.
So you might need to kind of titrate up the dose if the treatment duration's not long enough. And then if there are other coexisting conditions that are not being addressed, so things like anxiety and depression can exacerbate migraine, so those need to be addressed as well.
So what are the main preventative drugs that we should be aware of?
So there are various classes of preventative drugs. You've got your tricyclic antidepressants like amitriptyline.
Okay.
You've got angiotensin receptor blockers like candesartan, angiotensin-converting enzyme inhibitors like lisinopril, certain antiepileptic drugs like Valpro and topiramate, and beta blockers like propranolol and atenolol.
And the source material has advice on how to actually give these drugs right.
Yeah. So it gives you some really nice practical advice. So start low to minimize side effects and then increase the dose based on the patient's response and how they're tolerating it. And continue the treatment for, a reasonable duration. So maybe 2 to 3 months at a therapeutic dose before you decide to switch.
That makes sense.
Yeah.
And I noticed that they talk about some of the newer treatments as well, the CGRP monoclonal antibodies and botulinum toxin.
So these are kind of the new kids on the block, really.
Yeah.
And they are a really promising new avenue for migraine management. So these systemically administered monoclonal antibodies that target CGRP or its receptors, so aranumab, fremanezumab, galcanezumab, and ectinezumab, they are a new way of preventing both episodic and chronic migraine, and actually can also be used for cluster headache.
Interesting.
But it's important to remember that they're contraindicated in pregnancy.
Got it.
And then you've got your botulinum toxin A or BTA, and that's actually been shown to be effective as a prophylactic treatment for some patients with chronic migraine.
Okay.
And it's thought to work by reducing muscle spasm and release of these pain neurotransmitters.
Okay, great. Well, let's switch gears a little bit and talk about tension-type headache and medication overuse headache.
Okay, so tension-type headache is incredibly common.
Right.
The text describes it as pain radiating from the back of the head and neck, often extending to the periorbital region, and causing pain behind the eyes. It's typically bilateral. So the diagnostic criteria they give: at least 10 episodes lasting from 30 minutes to 7 days, at least 2 of the following: bilateral location, pressing or tightening quality, mild to moderate intensity, not aggravated by routine physical activity, no nausea or vomiting, and then no more than one of photophobia or phonophobia.
Got it.
So that's kind of your classic tension-type headache.
Okay, and treatment-wise, what does this sort of material say?
So treatment-wise, they say simple analgesia is often effective, so aspirin, ibuprofen.
Okay.
And then if people are getting them frequently, preventative treatment with tricyclic antidepressants has been shown to be beneficial. And there's also a role for cognitive behavioral therapy and physiotherapy.
Now, medication overuse headache. That
Hmm.
seems like a really important thing for us to be thinking about.
Yeah, medication overuse headache is really important to be aware of when you're managing patients with chronic headache. So it doesn't really matter what the initial headache type is, they can all end up with medication overuse headache. So what you're looking for is headache on 15 or more days a month. In a patient with a pre-existing primary headache disorder who's been using regular medication for more than 3 months for their headache, so that's your ergotamines, triptans, simple analgesics, opioids, all of them. And it's really important to counsel patients about the risks of medication overuse.
Absolutely.
And then the text says that for triptans and NSAIDs, you can stop them abruptly.
Okay.
And the goal is to stop the offending drug for at least a month.
Right.
And you have to warn patients that they might get a withdrawal headache. And that withdrawal headache can last, on average, about 3.5 days, but it can go on for up to 10 days.
Okay, so we're going to move on to neuralgias now.
You.
And the source material mentions that these are really important differential diagnoses for ocular or periocular pain.
Yeah, they're really important for you guys.
Yeah, especially when we can't find anything, structurally wrong on the exam.
Yeah, exactly. And one of the big ones that we got to talk about is cluster headache. And this is really interesting because it often gets misdiagnosed initially as a local ocular problem because of the ocular features. So the typical patient is a young to middle-aged man. And what they get is this stereotyped headache with autonomic phenomena that occurs pretty much daily for weeks. And that's the cluster period.
Right, so the cluster period could last for weeks.
Yeah, exactly. So it's a pretty miserable time.
Yeah.
The headache itself is unilateral. It's oculotemporal, so around the eye and temple. And it's excruciatingly sharp and deep.
Oh.
The onset is very abrupt and it resolves quite quickly. So it tends to last between 10 minutes and 2 hours.
Okay.
And one thing they mentioned in the text, which I thought was really interesting, is that, migraine patients, they want to be in a quiet, dark room.
Right.
Whereas cluster headache patients, they're restless and they're agitated. They can't sit still. They're pacing around.
Oh, interesting.
Because the pain is so bad.
Yeah.
They can get multiple attacks in a day, often at consistent times. So often early morning, and then after a cluster, they might not get any headaches for weeks or months.
Oh, okay.
And then you get these associated autonomic phenomena. So lacrimation, conjunctival injection, rhinorrhea, and you can get Horner's syndrome, which can be transient or actually permanent.
Interesting. Okay, so treatment, acute treatment, and preventative treatment. What do they say?
Okay, so for acute treatment, the most effective treatments are subcutaneous or nasal sumatriptan and high-flow oxygen, so oxygen delivered through a mask. And then for prevention, verapamil is often the first line, typically 120 milligrams 3 times a day. And they say that can reduce the headache burden by 50% after 1 to 2 weeks.
Wow. Okay, that's helpful.
Yeah. And then they mentioned some other preventative medications like topiramate, baclofen. Galcanezumab can be used in episodic cluster headache. And actually, they mentioned some interesting ongoing clinical trials that are using sub-hallucinogenic doses of LSD and psilocybin
Right.
for long-term reduction
Wow.
in cluster headache frequency.
Okay, very interesting. What about SUNCT syndrome? I noticed they talk about that as well.
So SUNCT syndrome, the name is a bit of a mouthful. It stands for short-lasting unilateral neuralgiform headache attacks with conjunctival injection and tearing.
Wow, okay.
So they're unilateral, orbital, supraorbital, or temporal stabbing or pulsating pain, lasting 5 to 240 seconds. And they occur between 3 and 200 times a day, so incredibly frequent.
Yes.
And they have marked ipsilateral conjunctival injection and lacrimation.
Yeah.
So to diagnose it, they say you need to have at least 20 episodes. And the thing that triggers these attacks is often touching the face. And sometimes you can get a secondary SUNCT where there's an underlying structural lesion.
Got it. Okay, so what about paroxysmal hemicrania?
So paroxysmal hemicrania, the name's a bit similar, but it is a different beast.
Okay.
So this is a severe unilateral headache, typically ocular, frontal, and or temporal. Brief, recurrent episodes, usually at least 5 a day.
Yeah.
And they get 1 or more ipsilateral autonomic phenomena. So tearing, injection, nasal congestion, or watering. Lid swelling or ptosis, it's more common in women than cluster headache, but it's less common than SENCT. And the really key differentiating feature is that it responds really well to indomethacin,
Okay.
whereas SENCT doesn't.
Got it. Yeah.
So that's a really good way of telling them apart. SENCT also has less severe pain, tends to affect men more than women, and has more marked autonomic features.
Got it. Okay, what about trigeminal neuralgia?
So trigeminal neuralgia, I'm sure you see this all the time.
Yeah.
These brief attacks of severe pain in the distribution of one or more divisions of the trigeminal nerve.
Yeah.
So it's a paroxysmal and sharp, multiple bursts lasting a few seconds, and it can be triggered by touching the skin.
Okay.
So things like shaving or motor activity like chewing.
Hmm.
Facial sensation is normal between attacks, and it's usually treated with anti-epileptic drugs like carbamazepine, phenytoin, sodium valproate, and occasionally they might need surgical decompression. And unlike the cluster headache, SUNCT and paroxysmal hemicrania, they don't tend to get prominent autonomic features.
Right.
So that's one way of telling them apart.
Okay. They mentioned primary stabbing headache, which
Right.
is sometimes called ophthalmodynia periodica or ACE-PIC syndrome.
Yeah, so primary stabbing headaches are these short, sharp, jabbing pains in and around the orbit and the temple. And they're literally described as like nail stabs or needle stabs.
Oh, wow.
They last from less than a second to a few seconds. They can occur as isolated episodes, or they can get them in little flurries. And the frequency can vary from occasional to, dozens a day.
Wow.
There are no other accompanying symptoms. There's no identifiable cause. There's no trigger. It's more common in women, and it can affect children.
Oh, wow. Okay. And then they talk about Rader paratrigeminal syndrome.
So Rader paratrigeminal syndrome tends to affect middle-aged men, and it's a severe unilateral headache with periocular pain in the distribution of V1, and they get an ipsilateral Horner's. The pain can last for hours to weeks before it resolves spontaneously, and the text really emphasizes that you need to exclude carotid dissection
Right.
urgently in these patients.
Yeah. Okay. And then they just kind of briefly touch on herpes zoster ophthalmicus and occipital neuralgia.
Yeah, so herpes zoster ophthalmicus often presents with pain
Right.
2 to 3 days before you get the rash.
Mm-hmm.
And then you've got to remember that you can get zoster sign herpes, so that's shingles without the rash. And then occipital neuralgia, they get these attacks of pain that start in the occipital region but can spread to the eye, the temple, and the face.
And the source material wraps up this whole section with a really strong statement about something we always need to be thinking about.
Yeah, they really emphasize that you've got to investigate new, severe, unexpected headaches immediately. Particularly in older individuals, you've got to rule out anything nasty.
Right. So let's kind of summarize what we've talked about today in our deep dive. I mean, we've gone through so much.
Yeah, we've covered a lot of ground today.
Yeah.
So really what we've done is we've gone through the main categories of primary headaches. So migraine, tension-type headache, cluster headache, medication overuse headache. And we've tried to highlight the key diagnostic features and the treatment approaches, and we've focused on, what's most relevant to you guys. So when your patients present with ocular and periocular symptoms, and then we've also touched on some of the trigeminal autonomic cephalalgias and other neuralgias that are important in your practice.
Yeah. And I think it's really clear that for neuro-ophthalmologists, having a good understanding of these headache disorders is essential.
Absolutely essential. You've got to be able to spot those red flags, and you've got to be able to pick up on those subtle differences
Right.
between the different headache types. And that's so important for guiding management
Absolutely.
and for, making sure your patients are safe.
And it makes me think about the future of all this. As we learn more about these disorders, we're getting better at treatment, but what are the things that you're looking forward to? What are those things on the horizon?
Yeah, I mean, it's a really exciting time to be in this field because our understanding of the pathophysiology is really advancing all the time. And there are all these new diagnostic tools and therapeutic options that are coming out. So, we've got to stay on top of it. We've got to keep learning, keep consulting resources like the ICHD3.
Yeah, definitely.
And I think, the really exciting stuff is the new therapies. So, we've got things like these highly targeted therapies and maybe even gene-based interventions in the future that could really revolutionize the way that we prevent and treat these conditions. And at the moment, they can be really debilitating.
Yeah.
So, it would be amazing if we could actually prevent them altogether.
Yeah, that would be a huge breakthrough. Well, thanks for joining me for this deep dive. It was a really fascinating discussion.
It was my pleasure. Thanks for having me.
And thank you to our listeners for tuning in.